Welcome back to Nurse Ed Scholar. And today's lesson of the Stop Fearing Dosage Calculation series, we're on episode number 6. And this one's titled Insulin Calculations and Blood Glucose Management. Now, I know that insulin is not really calculated, but it's one of the most, I mean, I guess it's significant, okay? It's a high alert medication and you will be administering it as a nurse. And so this video is really aimed to, present a scenario of a person receiving insulin and what to watch out for and things that you may come across and even how to read an insulin syringe. Okay. So, um I want to start off by saying, if you're working in a hospital and your patient's blood sugar is 328 milligrams per deciliter, okay, would you automatically give insulin? But what if I told you that doing exactly what the sliding scale says could actually harm your patient? So today, I'm going to spend some time talking about this through, I guess, like a patient scenario, like you're actually working in hospital taking care of one of your patients. And so the goal, you know, I have calculate insulin doses, but like I said, it's not really calculating, but it's part of the series. And so we're going to talk about, looking at an insulin syringe, determining the dose, looking at, blood sugars, recognizing, complications, what priorities you would be deciding, and, trying to make you see, how the NCLEX really wants you to understand this information. And so by the end, hopefully insulin will make sense and you'll understand how, determining when to give insulin uh, based on your patient assessment. Like when do you give it? When should you give it? Because I want to, I want to let you know, and I want to keep stressing this. You never want to, I guess, just give medications blindly as a nurse because that really can harm your patient. Okay, so with this patient, I said I was going to kind of do a patient scenario throughout this whole thing. So, okay, let's begin. The patient's name is Mr. Miguel Rodriguez. He's 58 years old. He weighs 94 kilograms. So if you're going to convert that, that's 207 pounds. He has a history of type 2 diabetes, hypertension, chronic kidney disease stage 3, hyperlipidemia. Okay, and he comes into the hospital because he has community acquired pneumonia. And so kind of write these down because we're going to talk about this assessment findings throughout, this video. But his current assessment, he has a temp of 101.8. He has a heart rate of 108, blood pressure 148 over 86, respiratory rate 24. His oxygen saturation on room air is 91%. And looking at his lab values, his current blood glucose is 328 milligrams per deciliter, potassium 3.2 milliequivalents per liter, and his white blood cell count is 15,000. I want you to remember, like I said, I want you to remember Mr. Rodriguez because everything that we kind of learned today is going to be based on this scenario. Because this is kind of how, nursing works. And, patients don't come in with one problem. They have several comorbidities. And so that's how we're going to present today. Okay. So, you're going to hear it in school, and they always talk about insulin is a high alert medication, right? You know, but why? You know, um, Minor mistake, and I'm saying minor mistakes because with insulin, everything is a mistake if you give too much. But if you give the wrong dose of insulin, it can cause some serious issues with your patient. Because too much insulin can cause, I have it on the screen, severe hypoglycemia, seizures, coma, even death. So when you're trying to determine when to give your patient some insulin, remember, actually holding out on insulin sometimes is actually the best route because if you give insulin at the wrong time, you can actually kill your patient or, or put them in a position to where you're going to have to call a rapid response and get all of these people, in the room to try to work on your patient to get him back to his normal state. Okay. So, when we talk about, Mr. Rodriguez, and we're talking about, his blood sugar, and, we say, well, why does insulin matter? So we know that his blood sugar is 328. So you're like, should I really give this insulin? Should I give it right now? What would happen to him if I don't have insulin? But you want to pause and you're going to say, okay, he's 328. Do I give it right now? But hold up, let me wait. You know, and this is why. You really have to understand how insulin works, how glucose moves from the bloodstream into the cell, the cellular metabolism, people's stress responses. You need to really understand why you're doing an intervention. That is so important. It's more than just a task of, oh, his blood sugar is high, I need to give insulin. You need to look at your patient as a whole and figure out, even though his blood sugar may be elevated, is this the right time to give this amount of insulin that may be ordered? So let's look at some patho, a little bit, what does insulin do? First, your patient's going to eat the food. And, food has carbohydrates and those turn into glucose, and the glucose goes into the bloodstream, and then the insulin, it unlocks the cell, and so then the glucose goes into the cell, into the body, and it provides the patient energy, right? So that's good. Food creates energy for your patient. Okay, but insulin is a big key, and our body makes its own insulin. So, when we're giving insulin, remember that, the insulin that we're giving isn't made by the body. And one thing I do want to say right here, when a person gets too much insulin from the outside, their body stops making insulin. Okay. They may talk about that in school or not, but in actuality, if you give your body too much of something, your body's going to say, hey, I don't need to make it anymore because I'm getting it from outside. All righty. And so, think of that as well when you're educated and you're talking to your patients when you're trying to educate on diabetes prevention. But let's move on. Without insulin, the glucose is going to stay in the bloodstream. And what happens is that the cells are going to starve because they can't use the glucose. And then the body's going to say, I need energy from somewhere. And so the body is going to break down the fat, all right, to try to come up with some energy. But with that, ketones are going to develop. And that's not really good, because when that happens, complications will happen. Your patient may develop diabetic ketoacidosis. They may even develop hyperosmolar hypoglycemic state, and both of these conditions are life-threatening. So this is worse than your hyperglycemia. Okay, but let's look at the signs and symptoms of hyperglycemia and actually hypoglycemia. All righty. So if your patient receives, let's just say they either receive too much insulin or let's just say your patient doesn't eat enough. Okay. So they'll, develop hypoglycemia and signs that they may exhibit would be shakiness, they may be sweating, they may get confused, they may even, be hungry. And I'm gonna say something, when I was working in the emergency room, where I had this patient come in, and on their chart said nothing about the patient being a diabetic. Okay. And uh, when I went to check on them initially, they were fine. The doctor went in and assessed them in the ER. They were fine. And as we were waiting for testing to come back, of course, you go in and you reevaluate your patient, you assess your patient. And I went in and she was confused, disoriented. And I'm like, what's going on with my patient? And uh, I was like, well, I mean, she's been here a while. What's her blood sugar? So I went and told the physician. The physician's like, well, they don't have diabetes. I said, well, and they said, well, go ahead and check it. Well, when I checked it, that patient's blood sugar was like 35. And they were like, "Oh my goodness!" So we were able to, give her some glucose, and things turned out fine. But I'm saying this right now when we're talking about hypoglycemia is that if you recognize the signs, even if the person doesn't have a diagnosis, of diabetes, or they're receiving any kind um, anti-glycemics, or insulin, metformin, those medications, the person still can develop hypoglycemia. So it's always good to know the signs and symptoms. I just want to throw that in there. And then if your patient has hyperglycemia, they may, have increased thirst, increased urination, they may be fatigued, they may have blurred vision. And so it's always good to know these signs and symptoms. So when you recognize them, you can kind of develop an idea of what is going on with your patient. All right. So with the other videos and the and many after this, I have this, this calculation roadmap. Now it doesn't actually all apply to insulin, but you can still kind of use it. With Mr. Rodriguez, his blood glucose was 328, right? So what's ordered? So you're going to have some insulin probably ordered, maybe on a sliding scale. What's available typically with a sliding scale, it may be regular insulin in U100, and we'll talk about what U100 means in a little bit. Then it says, what am I solving for? Well, if you're looking at a sliding scale, that's actually what you're, solving for, looking to see what range of blood sugar is going to determine how many units of insulin to give. Um, do the units match? And I guess basically, with this type of thing, making sure that you're using an insulin syringe, making sure that you're using the right vial of insulin, because there are different vials of insulin. So it's just making sure that you are giving the correct amount and using the correct syringe. Okay. Um, and as of setting up a calculation, is just making sure that you are going to draw up the correct amounts of insulin. And I have some insulin syringes coming up so you can actually see those. And then, we talk about solving, it's just making sure, I guess, again, are you giving the right amount of insulin? And then sometimes you may have to give two doses of insulin, and we'll talk about that as well. And then in the end, does this make sense? Does the amount of insulin that I'm about to give my patient, is it actually does it actually um, match with the patient's presentation at that moment of time? Because if not, it's not going to be safe. And I'm going to explain what I mean when I say, does giving this amount insulin right now make sense? It's going to come up in a little bit, and I'll explain more of what I mean. Okay, as you'll learn, there are different types of insulin. I have them on the slide. I'm not really going to talk about each one of them, but when you look at Mr. Rodriguez, okay, so Mr. Rodriguez, let's just say in the morning time, he was given a long-acting insulin. Okay, that was already given. So that could be like your Levemir, your long-acting. And then for lunch, he received a rapid acting. So that's your Humalog or your Novolog. Now, one thing I want to say with that is you're going to give Humalog or Novolog right when the patient eats. So that means that food tray is right in front of them, and they're about to put the fork to their mouth, and okay, you're going to give them their insulin. Because when you give that rapid acting insulin, that is for the food that they are about to eat. That is important because if you have a patient that is nauseated, that is drowsy, maybe a little confused, okay? And they have an order for insulin, the Humalog and Novolog, because it is rapid acting. If you don't think that they are going to eat that food at that mealtime, wait. I know you're supposed to give it when they eat. However, here's a quick story so I can hurry up and move on. There have been a time, I'm bringing students to the unit, and not the unit, to the floor. And there was this patient that, uh, that didn't, the, the nurse gave the insulin, but the patient didn't eat. The patient said they were going to eat, but something distracted them. I don't know, family came in, something was going on. And so they didn't eat at the time that they said they were going to eat. And so, of course, what happened? The patient's blood sugar plummeted because the insulin dose was based on the calories or the glucose that the patient was going to get with that meal. And when they didn't get the meal, they didn't eat it, the insulin still, the mechanisms, of action still worked, but it was too much. Okay. And so, of course, they had to call a rapid response. So that's why when I say maybe sometimes it's okay to delay the insulin until you know that the patient has eaten, is because of those times. Because unless you see that person eating and knowing that they've eaten enough, if you give that insulin too soon, it can cause, serious consequences on your patient. Okay, I digress. So let's get back to Mr. Rodriguez. And then at bedtime, he gets a basal insulin. Now, basal insulins would be the intermediate, which is NPH, and also, it could be a long-acting insulin. The reason why those fall under basal is because they provide a continuous release of insulin to control blood sugar levels between meals and overnight. And so this slide just kind of talks about basal insulin is, insulin that's working in the background. Like I said, it's controlling the blood sugar between meals and overnight. And when they talk about bolus insulin, it's given at mealtime. It may be given, extra insulin with, more or less when using a sliding scale, because sometimes your patient may receive a rapid acting and then regular insulin. So the rapid acting, like the Humalog and Novolog, is supposed to control the glucose that's going to be developed from that meal that they're about to consume, and then the regular insulin could be to control the sugar that they had prior to the meal. And I know that sounds kind of strange, but it's like we always check our patient's blood sugar, right? Before they get a meal. So when you check that blood sugar before the meal, that blood sugar receives insulin based on a sliding scale because that blood sugar before they eat may vary. So the sliding scale depends on the blood sugar. So you have one insulin for that. And then that rapid acting, that Novolog or that Humalog, that rapid acting insulin is for when with the meal that's sitting in front of them. And sometimes that gets a little tricky for students. Okay, so remember when I said, you want to make sure that what's available, like, you want to look on that so that bottle of insulin, because some insulin concentrations can be different. Some may be 100 units per 1 milliliter. Some can be 500 units per 1 milliliter. So I want you to please make sure you read that vial, you know, uh, and know what's in it. Because think about it, in this case, you could actually mistakenly give your patient 5 times the dose of insulin. Okay. And, that could really cause serious harm on your patient. And that's why insulin is a high alert medicine. And that's why when you start working or when you're in school, you're going to notice that there's going to be two people that's going to verify the insulin before you give it. Okay. Now, now I put this insulin syringe here, okay? And this is an insulin this syringe that you see on the screen. This insulin syringe is only for insulin. You do not use any other syringe for insulin other than, you only use an insulin syringe for insulin. And an insulin syringe will have this orange top on it, okay? You can't use any other syringe. So with this one, I tried my best with the arrow. Just say the order is for regular insulin, 6 units sub-Q. And so if you really look closely, maybe pause it, and you can see underneath that 5, you see a little line, and that is 6. So if you see 5, 10, 15, 20, 25, Well, the lines in between are 1. So it's 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So you really have to make sure that when you're drawing up your insulin, you are right on the line. And then you want that checked with somebody else because you know that I'm giving 6 units. So you're going to show another nurse your insulin syringe, and they're supposed to say 6 units. You'd be like, all right. If they say 7 or 8 or 5, but then that means, oh, well, I'm supposed to be giving 6. I need to go back and redraw up the insulin. Okay. So, well, I guess I just went through this. I'm sorry. But I guess I can say right here is, why insulin syringes are used. Okay, I'm gonna say that right here. I guess I should have said it with the last one. But it's to help your patients, actually easily administer insulin without a calculation. Even though we talk about insulin calculations, we don't, and we talk about that insulin syringe and how you have to use that because you know, we don't expect our patients to actually calculate insulin in milliliters. All righty. That's why we use the insulin syringes. Because if they tried to dose it like you would dose any other medication, the doses are, can be in fractions, which makes it really hard for your patient to kind of calculate and determine how much insulin to give. And so that's why insulin syringes are used. So that's just, that kind of just gives you a little background of why are we using insulin syringes? Well, this is why, because if we try to calculate insulin, our patients couldn't do it. And so this was devised for a better way for patients to be able to self-administer insulin. Okay, so so in this one, it's just looking at, and I have, the different I think, we did 6 units on the other slide. So you can kind of see where that line is for 6. And then you would be looking for 18. And I tried my best, and I think I did all right, pointing it to the 18. So if you have 18 units that you need to give, you will draw up to that 18. And then also the 27. What you can't see is that, in that plunger, they have that little plastic piece. And so that's kind of hovering over 25. But even if you take your time and count, you can see where 25 is and then 26, 27. And sometimes you're sitting there, trying to draw up, one of your eyes are closed because you really want to make sure that you dose your patient correctly with the correct amount of insulin. And it takes practice. And it's okay. It takes practice. Okay. So this is what I kind of alluded to before, the sliding scale. So Mr. Rodriguez, his blood sugar is 328. And so, you took his blood sugar, you take it multiple times during the day, and you're going to dose him on his how much insulin I'm going to give. And so you'll have this sliding scale. So between 150 and 199 blood sugar, you would give 2 units. And then, the next level 4, and then you go up. So for this patient, he has a blood sugar of 328. So how much insulin would you give? So you're looking And so you want to look for the blood glucose range that will fit your patient. So for Mr. Rodriguez, he would be in the range of 300 to 349. And so what you would do is say, okay, I'm going to give him 8 units of insulin for his 328 blood sugar. Okay, so we've taken Mr. Rodriguez's blood sugar. We have looked at this. We know it's 328. We have looked at the sliding scale. We know it's 8 units. So are we ready to give that 8 units? And actually, no. And the reason why I say no is because have you assessed your patient? Like we talked about before, his meal status. Did he really eat all of his meal? 8 units may be too much. Did you check his labs? We know that potassium is big when it comes to insulin, and we're going to talk about that. What are his labs? Is his potassium okay? Um, are we going to do an assessment? You still have to, look at his mental status, what's going on with him. You want to do a quick assessment of your patient at all times. And then you have to look at the insulin type. Are you sure? You got 8 units, but are you giving the correct 8 units? You don't want to give Humalog if it's asking for regular insulin. So you want to say, hold up, do I have what I need? Is it the right time to give my patient this 8 units of insulin? Okay, so we said we wasn't going to give the insulin, right? We're going to hold up. We need to assess the patient and we need to look at his labs. And you're going to your EHR, your electronic health record, and you look and you're like, oh man, his potassium is 3.2. Now, should we still give the insulin? Okay. And what does insulin do other than lower blood glucose? Well, insulin actually moves glucose into the cells and potassium moves with it. So the potassium in the bloodstream is where they received this lab result. So it was 3.2. But if you're giving that insulin, it is moving that potassium from the bloodstream inside the cell. And so what's going to happen? There's going to be fewer potassium in the bloodstream. Okay? And that's going to make the potassium level worse. And what's going to happen if you have low potassium? Why is it so important? Because your patient can develop cardiac dysrhythmias, and that is not what you want. So, would insulin make Mr. Rodriguez 3.2 potassium lower? Yes, it will. And this is how you should think. You're like, man, this is all the stuff I have to think. But yeah, this is how you have to think. We don't just administer medicine. We have to say, what is going on with my patient? Is this safe to give this at this time? So we kind of talked about this. What are you going to do? You're going to recheck the blood sugar, look at the potassium level that we talked about. Did the patient eat all of his meals? Do he have any symptoms? What are his symptoms that he's having? And you want to verify the orders. You want to verify the insulin amount that you're giving. You need to do all of these things. Now, understand when you are nursing, you're going to be doing all of this at the same time. But while you're a student, you kind of think of it one at a time. But as you practice and, continue to work, all of these things are going to, happen kind of simultaneously. Okay, it's going to happen all at the same time. Okay. All right. So let's moving on with Mr. Rodriguez. You looked at the 3.2 potassium. His blood sugar is 328, and the doctor calls, and you know, you're saying, hey, Dr. Billings, this is, um, nurse nurse I don't know, nurse Sally, I don't know. And I'm taking care of Mr. Rodriguez, a 58-year-old man who has been admitted for community acquired pneumonia. He has a history of type 2 diabetes, hypertension, chronic kidney disease stage 3, and what was the other one? Oh, hyperlipidemia, right? And I'm calling because his current blood potassium is 3.2 and he's NPO, so he can't have anything to eat anyway, right? And so the provider says, continue with the correct insulin, okay? And you're like, should I do it? Remember, 328 blood sugar, potassium 3.2, pneumonia diagnosis, NPO status. Then what you do is you look at the hospital policy. And typically, the hospital policy will say the patient needs a potassium replacement before giving the insulin. Because, like we said, it's going to move that potassium into the cell, and your patient can develop cardiac dysrhythmias because the potassium's too low, right? Too low potassium, too high potassium, bad for your patient. And that's where clinical judgment comes in. That's where safe communication comes in. And that's what you are as the nurse. You are that last line um, to your patient, and you want to make sure that you do your due diligence and protect your patient. All right. So, you know, I guess what I'm saying here is that, the blood sugar, the potassium, the patient's NPO, and that he has an illness, right? And I guess I want to say at this point, that you shouldn't give the insulin. The doctor said to give it. Now, I'm not saying go against doctor's orders. I mean, well, I mean, man, yeah, technically, it's not that you're going against their orders. It's just saying, just I can't give it right now. He didn't say he wasn't going to give it, but at this very point, you cannot give this insulin because there's too many things going on. And so, if you're a new nurse, or even if you're an experienced nurse, and you're having this communication issue with your provider, you're going to go to your charge nurse and say, "Hey, this is what's going on." You may have to escalate it to the unit director and say, "Hey, this is what's going on." You may need guidance, because a delay in giving insulin will do less harm than to give your patient insulin at the incorrect time. I mean, and you know, um, I know that we always want to give medicines on time because the hospitals have where, oh my goodness, you gave your medicine late and all this kind of stuff. But if you document correctly, you protect yourself. But if you don't document, you're gonna hear people say if it's not documented, it's not done. So if you document it, it'll be okay because they'll be able to read the story and see why you didn't give it and see what happened, and you'll be okay. Okay. So we're still talking about should I give these 8 units of insulin, right? So here we go. Mr. Rodriguez gets nauseated and he's NPO. Remember? No, nothing by mouth. So do we still give this rapid acting insulin? He's nauseated and he can't have anything to eat. Okay, we talked about, you know, you give rapid acting insulin when there's a meal in front of them. There's no meal, right? We talk about giving sliding scale insulin. We talk about, the risk of hypoglycemia, confusion, shakiness, um, uh, you can, have other complications. Um, we know that he can't have anything by mouth. So if you give the insulin, well, he's not eating anything, so he won't be able to create glucose if he drops. So, what are we really going to be doing with him? So you say, well, I haven't taken his blood sugar in a few minutes. So now you take his blood sugar and he went from 328 to 82 and you didn't give any insulin. And that happens. So now do you give the insulin? No. You know why? He doesn't need it. He hasn't eaten. He's nauseated. Yes, he was high, but something happened in between that time. And this happens in real life. You start to give something, and then something else happened, and you're like, I'm glad I didn't give that insulin. Okay, it happens. And so now, that was at 2 o'clock, blood sugar 82, right? He's still in PO, nothing by mouth. Now let's just say at 4 o'clock, he becomes suddenly, he's sweaty, he's shaky, he's confused, right? And you're like, man, wait, that's signs of hypoglycemia, right? And then you take his blood sugar again, and it is 48. What do we do? Ooh, 48. What do we do? He's 48. What do we do? Do we give insulin? No way, right? So what are we going to do? We're saying, hey, he has hypoglycemia. You are going to follow your hospital's protocol. What do? You may have to give, they may want you to give him some D50. Um, and then, of course, you're going to recheck his blood sugar if you give him D50. If he's awake, um, but he's in PO. But there are different things. There's something called a 15-15 rule, and this is a person who is not on NPO, so they can eat their blood sugar drops. So 15-15 rule is 15 grams of carbohydrates, you wait 15 minutes, and then you recheck the blood sugar. On that repeat blood sugar, if their blood sugar is still under 70 milligrams per deciliter, then you give another 15, right? And that 15 grams of carbs could be like a half a cup of juice, a tablespoon of sugar or honey. It could be 6 or 7 hard candies like, I don't know, lifesavers or something, right? Or they have glucose tablets, so you may be given 3 to 4 glucose tablets, right? So you give one of those, you wait 15 minutes, and then you repeat it again. And if it's less than 70, and that's whatever the hospital protocol is. So we're saying it's 70. And then it's less than 70, you give another 15. Now, if the patient is NPO or unconscious, then you may have orders for IV dextrose, IV glucagon, you know, for your patient. And you're still going to, after you give it, you're still going to reassess your patient. You're still going to check their blood glucose, and then you are going to communicate your findings with your provider. Okay, so we're getting to the end. Hang in with me. So now it's 6 p.m. and your patient is improving. Their blood sugar is 128. Their potassium is 3.9 because while all of this was going on, you hung some K riders, so you gave them some potassium replacement. Because I want you to remember, nurses always treat the patient, not the number. We always want to make sure that we treat the patient and what's going on. Of course, numbers matter. But as you can remember in the beginning, his blood sugar was 328. We gave absolutely no insulin. And then we had to give him glucose. And now he's 128. So you want to treat the patient. So when we talk about insulin calculations, students can make mistakes. Um, they may drop the wrong insulin. Wrong syringe. We talked about insulin is only given in an insulin syringe. Wrong time. You know, um, they don't check the blood sugar. They don't look at the potassium, levels. They don't pay attention if the patient ate or not. And those are things that can cause big problems. And so I'm gonna throw this in there. We're almost to the end, but I like to, give real life examples. So, um, um, as an instructor, yeah, I had a student and we get distracted. I guess I should have put on that common mistakes being distracted because student was drawing up insulin and they were talking. And I was watching the student. The student was drawing, they got to 5 units. They went to 10 units. They went to 20 units. And when they got to 40 units, I asked the student, how many units are you supposed to be giving? And they said 10. And they looked at the syringe and they just freaked out because they had gotten to 40 units being distracted. And this is one thing that you can't do with insulin is be distracted. Okay. So I should have listed that as a common mistake because it happens. Alrighty, so you're gonna always verify, like I keep saying this because this is really what you need to be doing. Looking at the patient's meal, making sure that they're eating the meal, checking their blood sugars, making sure that they're given the correct insulin, assessing their patient. Mr. Rodriguez during this whole scenario, he received some antibiotics, hydration, monitoring. You know, I say this and I'm going to keep saying it. Your job doesn't end when you give medications. You have to make sure you're assessed before, you have to make sure that you assess and evaluate after to make sure that your interventions were correct. And if something goes wrong, you can recognize it quickly. Alrighty, so what did we learn today on the screen? We talked about basal versus bolus. We talked about, sliding scales. We looked at, kind of some signs and symptoms for hypo and hyperglycemia. Um, and we talked about, and before we talk about key takeaways, we did talk about just because someone's blood sugar is 328 do you automatically give insulin? And sometimes that answer is no. And we talked about why. You know, you have to look at, does the insulin match the patient's assessment or presentation at that time? Did we look at the blood glucose? Did we look at the potassium level? Did we make sure that the patient ate the meal that went along with that acting insulin? Did we give the right insulin type? We talked about that. We talked about, orders. We talked about safety. We even talked about communication with your provider. It doesn't have to be nasty when you communicate. It's just your patient's presentation and you want to do the safest action for your patient. And so that's it. Thank you for hanging out with me during this video. I really hope that, you watched this video and you kind of learned about insulin. It's more than just drawing up the insulin and giving it. There are so many things that are involved when you're giving insulin to your patient. Hopefully, I helped you learn to kind of think of things that you would need to know with insulin administration, because that's actually what keeps your patient safe. And that's what the NCLEX is testing, right? So hopefully if you found this helpful, please let me know in the comments. Um, our next video is going to be on another high alert medicine, which is heparin. You'll learn about anticoagulants, lab values, bleeding risk, and I guess doses calculations, but you'll see what I mean. And hopefully it'll all come together in real practice. So thank you for watching Nurse Ed Scholar, and happy studying from Nurse Ed Scholar.